We have Dr. Anneka Johnston from Rush University Medical Center, Chicago, speaking about considerations for assessment and treatment of neuropsychiatric symptoms of ECD. Welcome, Dr. Johnston.
Hi, everyone. Thank you for having me. As he was saying, I'm Dr. Anneka Johnston. I'm a third-year psychiatry resident at Rush, and my co-author, who isn't here today, is Dr. Jonathan Kaplan, who is a board-certified internal medicine and psychiatry attending who works within our psycho-oncology department. And I'll be presenting on considerations for assessment and treatment of neuropsychiatric symptoms in ECD. And I know I'm what stands between you and your next break, so I appreciate your attention for the next few minutes. And I unfortunately have no financial interests or relationships to disclose. My overview is, by the end of this talk, I'm hoping you'll be comfortable with understanding the current ECD psychiatric landscape, the ECD psychiatric burden and how it compares to similar populations, the benefits of psychiatric treatment, how to approach initial psychiatric screening, and how to also approach initial psychiatric treatment within your own practices. And we've talked a lot today about how there's been a giant paradigm shift with the Erdheim-Chester treatment, with targeted therapies increasing survivorship over the last 10 to 15 years and changing it from more of an acute threat to, in a lot of patients, a chronic condition. And with this becoming a more chronic condition, there is a rising chronic neuropsychiatric symptom burden that a lot of our patients are navigating. And Diamond et al. In 2019 did a phenomenal study where they had patients self-report what symptoms were most bothersome to them. And you can see here that 50% of patients brought up depression, anxiety, 52% brought up a memory impairment, and 72% brought up severe fatigue. And if we take a step back and compare these numbers to what we see in general cancer population patients, this is much, much different. In general cancer population, you have about a third of patients reporting depression and anxiety. If you adjust that for publication bias of the studies they were looking at, it's actually even more than that. So you're starting to see this separation with ECD patients and general cancer population with psychiatric symptoms. And if you ask an ECD patient, have you ever had a past major depressive episode? 80% of them will say yes, and compared to the general non-cancer population, that's compared to 16.2%, a very, very large difference. And this same study found that ECD patients had a very high prevalence of agoraphobia and anxiety disorders as well. That was markedly different from the general population. So why do we see this? It's probably multifactorial. You have some patients with brain tumor burden. You have patients with brain perivascular involvement. We know that inflammation affects the mood centers within the brain. I could do a whole talk just on that. And you also have the chronic stress of living with a very serious life-threatening condition. So depression and anxiety in ECD are not merely psychological reactions, they're the result of a compounding pathophysiologic triad. So why does this matter? There's been more and more studies that depression and anxiety can be linked as a potential threat to cancer survivorship. So look on the left side of the screen. You can see higher incidence of cancer incidence, higher cancer-specific mortality, and higher all-cause mortality in cancer patients if they have depression and anxiety. And when I first saw those numbers, I started questioning, is there some reverse causality here? And I'm sure there is. If you have a patient who knows that they are likely dying, of course they're going to be more depressed and anxious. But if you have a depressed and anxious person, they are going to be less likely to engage in medical treatment, less likely to see their providers, less likely to exercise, less likely to eat well. So I believe there is a lot behind these numbers. So what may get in the way of your ECD patients getting psychiatric treatment? Let's talk about this. I think the first thing that gets in the way is the assumption that primary care will take care of this. And I think it might be a bit of a stretch. My husband has Erdheim-Chester disease, and for 2 years he was under the impression that his oncologist was his primary care provider. I don't think his oncologist felt the same way. And I imagine a lot of your patients are similar, where they have a lot of specialists. It's hard to keep up with a PCP, and it would be asking a lot of a PCP to know enough about Erdheim-Chester disease that they know about the higher neuropsychiatric symptom burden as well. And then once you catch these higher levels of depression and anxiety, how do you ensure that your patients get to see psychiatry? Probably depends on your system, and there may be barriers to access there as well. So while patients receive world-class oncologic care, they may be missing out on neuropsychiatric management. So my recommendations is to propose a ECD behavioral health pathway, where we put in protocolized screening within ECD centers, which would be relatively easy to do bi-yearly GAD-7 screenings for anxiety, bi-yearly PHQ-9 screenings for depression, and these screenings risk stratify your patients for you. I would recommend if you have a patient screening moderate or severe, you refer them to psychiatry as well as psychotherapy. And I want you to also get more comfortable throughout this talk, potentially evaluating your patients for psychiatric conditions and starting treatment on your own, because it can be a couple months before they start seeing us. And our treatments, unfortunately, take a while to work. So the first part of an evaluation is the beginning of wisdom is to call things by their proper name. If you have an ECD patient with depression and anxiety, is it merely psychological? I want you to consider vitamin deficiencies, B12, vitamin D, folate. We know that endocrine disruptions are very common in ECD. Consider hypothyroidism, hypogonadism, adrenal insufficiency, hyperprolactinemia. All of these can cause mood symptoms in ECD. The medications we use cause mood symptoms, and whenever you're evaluating a patient for depression and anxiety, ask about substance use, ask about psychosocial stressors. So let's talk through what an initial approach in your office could be. And I want to start with the SSRIs and the SNRIs. Specifically, in an ECD population, and in many populations, first-line treatment for depression and anxiety. They have good side effect profiles. They're anti-inflammatory, and they also enhance neuroplasticity, which is our brain's ability to adapt, regenerate through brain-derived neurotrophic factor. Potential downsides in ECD: you have sexual side effects in a population that may already have hypogonadism. You have a small increased risk of bleeding in a population that you might want to do a procedure on. And we always have to think about drug-drug interactions. So I pulled 5 of the globally more commonly prescribed ECD medications and took 2 of my more commonly prescribed antidepressants. And the only interactions I found was some of them both prolong QTC interval. It's not a full contraindication, it's just something to monitor and be aware of. And I want to highlight 2 specific options that I think could be good for an ECD population. The first one is duloxetine, efficacious for chronic pain. I would note that it has a higher dropout rate than other SNRIs and SSRIs due to GI side effects, but if you have a patient with pain, depression, and anxiety, it could be a good fit. I also want to bring up vortioxetine, which you may or may not have heard of before. It's a multimodal antidepressant. Think of it as an SSRI plus, but it has proven pro-cognitive benefits, a more favorable sexual side effect profile. It's anti-inflammatory, and because of its anti-inflammatory and pro-cognitive nature, there's been good studies showing its place in Parkinson's disease, depression, and COVID-19 related depression. And drug interactions for this, there's a moderate interaction where CYP1A2 inhibition may increase duloxetine if you're on vemurafenib, and CYP3A4 induction may decrease vortioxetine if you're on dabrafenib. And again, not full contraindications, just something to be mindful of when you're dosing. So these are my starting options that I would recommend you initiate in your office when you see a patient with depression and anxiety in ECD, and I chose low doses, and these are ones that are all quite safe, quite efficacious, good tolerability, that you can get started. And then I want to take it a step further and talk about how I would approach this patient population should they come to psychiatry. And I would think about the gabapentinoids. So gabapentinoids can be amazing for neuropathic pain, anxiety, improved sleep quality, sleep maintenance. Yesterday at the patient and family session, a lot of patients brought up difficulty with insomnia. This could be helpful for that. Great substance use disorder treatment. They raise the seizure threshold, and there are preclinical evidence of anti-inflammatory effects. Potential downsides in ECD. A year ago, I would have told you we should have gabapentin in the water. I now don't think so. There have been more and more studies coming out with long-term risk of cognitive impairment with this medication, and this is a population, as we've talked about, that is high risk for neurodegeneration. You have sexual dysfunction with gabapentinoids, daytime somnolence, they require renal dosing, and they're more effective for neuropathic pain than bone pain, and this population may have both. And no big drug-drug interactions. I would also consider reaching for bupropion. It has proven efficacy in cancer-related fatigue, improves cognition, low motivation, lower rate of sexual dysfunction. Preclinical studies have shown anti-inflammatory effects, and the wait list you see with bupropion may be good for those on steroids. Potential downsides in ECD is it can worsen anxiety, and there is dose-dependent seizure risk. No big drug-drug interactions. Along the lines of bupropion, I really want to highlight dextromethorphan, bupropion, or Auvelity. It's a more newly FDA-approved antidepressant. It's multimodal, fast onset of action, so people can start to see benefits even within a week of this medication. It's anti-inflammatory, it's neuroprotective, sigma-1 receptor agonism, which has been studied as a potential novel target for preventing neurodegenerative disease. And because of the dextromethorphan, it may be beneficial also for pseudobulbar affect, which affects a lot of ECD patients. So you could hit multiple birds with one stone. I will note, too, the NCCN guidelines mentioned stimulants, that methylphenidate appears safe for ECD patients with severe fatigue, though, of course, consider cardiac history. And off the beaten track, I wanted to mention a few other things. All of these, omega-3s, L-methylfolate, minocycline, celecoxib, Mediterranean diets, avoiding inflammatory foods, they have proven benefit for depression and anxiety and reducing inflammation. So if I had a patient with ECD in my office who is depressed, anxious, and inflamed, I would be considering all of these things. I would also, of course, be bringing up psychotherapy and exercise in addition. So to cluster symptoms, if I had an anxious, depressed patient with ECD, I'd probably start an SSRI or an SNRI. I'd consider a gabapentinoid. If I have a fatigued, depressed patient with no motivation, bupropion would be my first choice, plus or minus an SSRI, SNRI, and I would consider dextromethorphan bupropion as an alternative or adding a stimulant. If I had an anxious, depressed patient with neuropathic pain, duloxetine is a good choice, as are the gabapentinoids. And if I had a neuroinflamed patient with mood symptoms, I would consider vortioxetine, omega-3s, L-methylfolate, anti-inflammatory diets. So for takeaways today, as survivorship improves in ECD, there will be a growing pool of patients navigating neuropsychiatric symptoms. Treating these symptoms aggressively may help improve survival. At minimum, it will certainly improve your patient's quality of life. Please rule out biologic causes before assuming mood symptoms are fully psychiatric in nature. We know this patient population has biologic causes that could be pushing mood symptoms. Screen and refer often, screen and refer early, and please start the treatment if you can in your office. And here are 5 pages of references. Any questions?